Streamline your practice with Confido Health, the AI virtual assistant that speaks any language. Whether it's during business hours or after hours, Confido handles patient calls, resolves 90% of inquiries, and helps with follow-ups and care coordination. With Confido, your staff can save 2 hours a day, and your patient engagement will improve dramatically. Trust Confido Health to handle patient calls so you can focus on what matters, growing your practice. We use it in our practice, and Confido has been great at helping us grow. Hi, I'm Dr. Demetrio J. Aguila III. I'm a peripheral nerve surgeon, I'm an ear, nose, and throat surgeon, and I'm also a plastic surgeon. I'm the host and founder of the Direct Care Movement podcast, where we dive into the intricacies of direct care, whether it's direct primary care or direct surgical care. You can find out more about what this movement is and where it's going and where it came from. And I'm excited to welcome onto our show today, Matt Ohrt from Self-Fund Health. Thank you, Matt, for joining us today.
Great to be with you. Yeah, I look forward to the conversation.
Awesome. Matt, why don't you tell us a little bit about yourself?
Yeah, absolutely. I've got a kind of an unexpected story. I tell people that I find myself on an unexpected path, but a very adventurous, very meaningful path. And so I've always been entrepreneurial and kind of a problem solver, if you will, but I found myself after grad school working in the corporate world, if you will, for 25 years, which shows my age a little bit. But I worked in HR, and my passion was to help people, and still is my strong passion to help people. But I was kind of an adventurous, maybe somewhat unique kind of HR person, and that I initiated change and led change, and that was one of my passions as well in school, of how to lead transformational change. But really, humorously, didn't care much about the benefit side, as it's called within companies, and didn't find it very interesting. But the last 1/3 of that career, I found myself in a VP of HR role for a company called Merrell Steel in central Wisconsin, and really wasn't planned even when I was hired. But we ended up very early on transforming an already self-funded health plan. And really learning along the way. We did some things out of order, as I know today, but we ended up switching all of our partners and to trustworthy partners, as I call them. And we ended up implementing direct care and really kind of sparking a movement within the state. And we saw over 5 years, we saved about $5.5 million off of our healthcare spend, off the previous trend. We ended up and we increased the care. We increased the quality of care and accessibility of care greatly, and ended up winning awards. And then that just kind of boosted all the actions that happened thereafter. I co-founded a company called Self-Fund Health. We modeled it after the plan I created at Merrell Steel, and we're taking that to employers throughout Wisconsin and Minnesota and Iowa today. We're growing as fast as we can. We're a health plan, and we work through forward-thinking advisors. And then that led to writing a book. That was one of my passions. Writing a book is not easy, as you might imagine. It takes time, and it takes just a ridiculous amount of work. But it was really a gap. There was a literature gap in terms of how employers can do it, how physicians can do it, and this buyer-seller relationship. And maybe we don't need a lot of the mess that's in the middle. And so how to form that. And then since that book came out in July of last year, I've been traveling the country in 25 cities. I've got one left, Chicago, in November this year, and on stages, and just sharing this good news, if you will, of this free market movement and the exciting things that we're doing in Wisconsin, maybe as one of the model states. So really excited to share that with you today.
Awesome. Why don't you tell us a little bit about the book?
Yeah, the book is something that was floating in my head for probably 3 to 4 years. It's about 9 years. It's 25 years, but really 9 years worth of experience in this new way. The first part of my career, all I knew was what insurance handed us and what insurance taught us, which is a losing game for the buyers, is what I've discovered. This monopoly kind of game that usually there's only one winner monopoly, and it's one seller. So I came to the conclusion that I couldn't win with the current system, and that we were going to have to get out of the box, as you mentioned earlier, right? Or just throw away the box. How about we just throw away the box and we'll just start over? And that's essentially, that's right. And that's essentially what we started doing on a smaller scale at Merrell Steel. Now, I didn't have the vision to say where we would be today. If you asked me 5 years ago, I never would have imagined that we would have progressed as far as we have as a state with the doctors involved and so forth. But it really is a process. We call it the Employer Healthcare Success Formula. And it's a process for employers and everyone involved in a self-funded health plan. Anybody who wants to practice free market medicine to get in this game in a way that doctors can practice healthcare like they dreamed of in school, the reason they went to medical school, and employers can buy things like they do in a fashion that we do everything else. Employers are already skilled at this game, is something that I say often, right? This isn't a new skill. Employers know how to buy steel. They know how to buy supplies. They know how to buy office supplies, right? Very well. They'll pinch pennies on notebooks and all sorts of things and paper and sticky notes and are pleased when they can save 1% or 3% off of something they've been purchasing a lot of, yet we have 20 to 30% of healthcare spend on the table that's probably, in many cases, a wasteful spending. And then we do nothing about that. So that's one of the spotlights that we shine to say, do you realize your second or third largest expense is full of absolute non-value-added spending, full of waste?
Sure. So now you mentioned, self-insured employers, and, some of our listeners, they may be familiar with that concept of self-insured versus level-funded versus fully insured. But for those that aren't, can you give us a brief tutorial?
Yeah. Yeah, and I like to point out, there seems to be a huge amount of misunderstanding and oversight. And I think when I say this, many will connect with this. It's really important. There's two really big parts to a health plan for an employer: how you fund it and how you manage the risk, which goes on that side, and then how you spend it. And how, in other words, are you buying healthcare or buying insurance? So as you mentioned, how you fund it is really important. You need to have the right kind of funding in terms of you can go fully insured. Typically, if you're smaller, I think there needs to be new options for that group because they're powerless at renewal. But that's a simple pay the premium. The level of funding is in the middle where it feels like fully insurance. You're paying a premium, but if you save money, you might get some back. And then what we call traditional self-funding is where you would have a stop loss, both for an individual and sometimes aggregate, that would protect you from big hits. Now, the largest of the large employers don't need that. They can completely self-fund, but a traditional self-funded plan is just having what we call stop loss. And so essentially, but if you save money, if you spend wisely and you have a good medical strategy, you can lower deductibles, you can lower premiums, or you can buy new trucks for the business, whatever it may be. And then the members, of course, save equivalently. And then, and so that would be the way to do it if you're big enough. And typically, we'll say on a traditional self-funded, maybe over 100 employers. There's not a set 100 employees. There's not a set number for that. But generally speaking, below 50, it gets more difficult to do level or self-funded.
Sure. So as we talk about the healthcare plan, or the healthcare plan as opposed to a health insurance plan, I think there's a misconception in the general public that health insurance is healthcare. And I noticed that you had differentiated the two. Can you dig into that a little bit more?
Yeah, it feels like 99% of the talk is all about the funding side. And again, that's critically important. But why aren't we talking about our spend? If you said that my household budget is broke, you would have to look at both sides, wouldn't you? You'd say, well, here's how much money is coming in. Here's how much I make. And you wouldn't say, okay, that's it. We'll just stop the discussion. We must need different car insurance or something. You'd say, no, how often are you going and buying all these things? Or what are you spending your money on? And so forth. And so we look at both sides. So when we talk about healthcare, isn't that really what we're talking about? Somehow insurance, the big insurance industry has really kind of taken over things. And they've actually got us saying things like, when we think of healthcare, we actually call it health insurance. And I would encourage the listeners, and especially those future doctors out there, future nurses, what are you providing, right? And really, Do we need that kind of health insurance involvement for everything else? Because they're answering, in many cases, big insurance is answering to Wall Street, and then it just gets us off track from there. So we need to focus on providing quality healthcare. Healthcare, as they say, isn't really that expensive. It's very affordable. It's when we start adding in all these other things that it becomes unaffordable as it's become today.
Sure. So you mentioned the direct care model and how that fits into all of this. Obviously, a big area of your expertise is making all those pieces fit together so that the cost makes sense in terms of what you're actually purchasing. So how does direct care, whether it's direct primary care or direct specialty care, impact an employer's health plan?
Yeah, and what it is it's the current solution. We almost wish we didn't have to talk like this, right? Because we're not really against anyone in this movement. We're not against hospitals. If there is maybe a common enemy, if you will, it might be the big insurance who don't seem to have any care for our lives or what have you. But theoretically speaking, we're not against anyone. And so anyone who really wants to provide high quality healthcare at a visible, affordable price, we'd love to talk with you. What's happened is big insurance has gotten in the game, and they've had an influence on the hospitals' ways of doing business, and many of the brokerage firms as well, who are advising employers, and they've kind of spoiled this game, if you will. And so, and we realize that they're making a lot of money doing it. All these entities, the hospital systems, the big insurance in the middle, and the brokers are all making big money. So this notion that they say someday this generic they, we don't even know who they is, but they will fix it. And I always come in and I would say, no, they won't actually, because it's not a problem for they. In fact, they're getting very wealthy on it. So what we have to do, and we can't go in, if my neighbor has a problem, I can't go fix my neighbor's problems. That's my neighbor's problem to fix. So what we have to do is realize that there's a monopoly here, that what happens in monopoly, you have no power to walk away. If we go on a truck lot and we don't like the deal, we go to a different lot. If we go to a restaurant, we go to another restaurant if it's not a good service or good food or good prices and so forth. Same with the grocery store. Same with everything else we buy. In healthcare, that's been limited. This guise they call a network is really to create a monopoly, and then we still don't have visible prices. So what we're really wanting to do is and that's where the direct part comes in. Guess what? The doctors are just as frustrated with these systems as the patients are. And how ironic is that? You have the buyers who are frustrated, the employers and the employees on the commercial side of healthcare, which is half of the market in the US. And the sellers, or the ones truly providing the healthcare, the doctors, if you will, are just as frustrated. Yet these are the two key components of this model. And so we find that when the doctors break off, just as they're doing in Wisconsin, and I'd love to share some of those details with you, what they're doing in Wisconsin is they're going off and starting their own practices, just like it was 20 or 30 years ago. And what we find then is we find very affordable care, and we find time-oriented care. We find that you can reach your doctor and all sorts of things outside the office. And we find that ends up being a win-win situation, a win for the doctors and a win for the buyers, the employers and employees. And that's simply what we're after, is a sustainable win-win.
That's awesome. So let's talk more about that. Let's talk about the physician component in all of this. How do doctors fit into this? And where are the doctors having an impact in this model that you've set up?
Mm-hmm. Yeah. And so what we found is this notion of direct primary care. So each state's a little different. I just met North Dakota's, I believe, first DPC in Denver at a conference about a month ago. The very first and only. Now, we could be missing some, so we'll be careful. If there's some out there, let me know. Send me a note. But what appeared to be their first one. Now, in Wisconsin, it appeared that the first one was 2010 that we know of. And I think that's accurate, and I think that's pretty close if we happen to be missing one. But right around 2010, two of the bigger ones that are operating today started in 2012. But there was an article in a Madison journal in 2020, just 4 years ago, mind you, that Wisconsin had 15 DPCs, direct primary care clinics in the state, not clinic companies, but actual clinics. And what's interesting is kind of almost inadvertently sparking a movement at Merrell Steel. Central Wisconsin, which is one of the most rural areas of the state, actually started the movement. And so the clinic that I partnered with for our care, we were their very first employer. They had done some community work before then. We were their first one. 5 years later, they had 37 clinics.
Wow.
But we find ourselves at a pace of over 25 new clinics per year, because today I count 131. I'm tracking it on a spreadsheet. I can hardly keep up with them. And it makes me smile. I go to Denver and I met the 131st, I believe. Yeah, 131. I had to go to Denver to meet them. And then I go somewhere else and I meet someone. I go to Vegas and I meet someone from Iowa, just across the border and so forth. But yeah, 131. And we're seeing the same. These are doctors that are frustrated starting their own practices. And then as they grow, some of these doctors now have 2, 3, 4, 5 clinics. So then they can hire. So somebody that maybe a nurse or a doctor within the hospital systems that maybe aren't comfortable starting their own practice, they can go join an independent practice and still practice medicine like they want to. So there's really 2 options for that group.
Sure. So we've got 2 key components, right? We have the seller, in this case, the physician, direct primary care doctor or direct specialty care doctor, or maybe a direct care surgery center or imaging center, physical therapist, something along those lines. We've got the buyer, who in this case is likely a self-insured employer. But then we've got a third key component. And Matt, you're obviously a very modest person. You don't want to toot your own horn, so I'll toot it for you. We have what I like to think of as the connectors, right? The people that bring together the seller and the buyer, and that would be you. And so your piece of this puzzle is rather critical, because the employer, the buyer, doesn't know how to structure all this stuff, doesn't know how to reach out to all these physicians and all these different facilities and say, hey, we want to work with you. And then somebody like myself as a physician, I don't have the time or the resources to go door to door to every single employer and say, this is what I have to offer. So talk to us more about where you fit in.
Yeah, and that's where we ended up in creating Self-Fund Health. And even when my co-founder, John Barron, and I joined, we didn't have our specific business model developed. We had actually joined before we even had that finalized. Of course, I had done that at Merrell Steel, so we had the foundation. But we realized that this is complex for an employer. Stacy Richter jokes, HR folks don't go to HR school to run an insurance. It's even calling it insurance, aren't we? Run an insurance business off the side of their desk. It really should be healthcare purchasing service. But when I counted up the pieces that I had assembled, it was something like 32 pieces and partners. And so even from a knowledge, now hopefully my book helps with that, which was the goal of the book. But assembling all this, and that's what we've done at Self-Fund Health, is we've assembled trustworthy partners, standardization, case management, in-house nurse support, et cetera, just a whole list of things, all the key components of a health plan. And so instead of having to reassemble this monster by yourself, you can go out and partner with us, and then we'll oversee it. And it's high tech. We've got real-time visibility, which is almost unheard of in the industry, of the medical and the pharmacy claims. And so we're managing with nurses that are overseeing this on a daily basis, talking with patients on really a daily basis. And that's in contrast with these health plans that often they kind of set it and forget it. They set it up in January. They start in January. In December, they say, how did we do? And we would say, we asked that on January 1st and January 2nd and January 3rd and so forth. Well, maybe not the 1st. We'll probably celebrate the new year first. But you get the idea, right? That we believe it needs to be actively managed. And so we want to support patients through the process. And that's really the only way you're going to get good results at the end of the year. I don't guarantee this in any form or fashion, but I can tell you that Merrell Steel is on their 8th year in a row of no premium increases to their health plan. They're running about $40 a month for single and $160 a month for family, and it can be free after that. So these are the kinds of outcomes that, and when you put all these pieces together and work with great doctors like yourself, this is what can happen.
So now you mentioned that that Merrell Steel they're on their 8th year, no premium increases. How does that compare to the industry average?
I think we're seeing the last time I looked, we're seeing industry average was something like 9 to 10%, depending on how you slice it per year. When I talk with employers, I talked with one or two last week. One of them had a 30% increase. I mean, we're seeing the highest one I've ever heard was 100% increase in 1 year. I don't know how anyone would sustain at that. One of the things we look at, one of the concepts is that the insurance industry, again, is kind of maybe got us to play their game that the patients only look at the car. And so all they're looking at is what their share is, but we're never looking at the total price, are we? Where else do we shop like this? Oh, you only pay $2,000, but the truck's $100,000. It should have been $50,000. No one cared. No one looked. So we look at the card. What we want to do is teach people and set up the plan design so that they look at the total cost and their cost. And if the plan saves money, guess what? We can make it no cost to the member and at a higher quality. Because this year's total claims cost are next year's premium increases. So somebody may have so-called great insurance and they say, I have a low deductible. I don't care what the spend is. And then they get disappointed when they go into next year's enrollment meeting and get the big increase because they still contributed to that. Not really isn't their fault because the plan wasn't set up correctly. But those are all the things we want to look at because it's the premiums that are mostly going up and the plans unraveling. That even if you have a low deductible today or a low premium, if you don't structure your health plan in what we're talking about, it's not going to last. You're going to see your plan unravel.
And in a more conventional model, like where you came from before you started making these changes at Merrell Steel, correct me if I'm wrong, but the incentives were lined up to keep people ignorant, right? I mean, as opposed to getting them on board with the bigger picture, kind of like you've done now.
Yeah, there was no connection that if the plan saved and shopped wisely is a better way to say it. It's not just cost, it's everything. But if the plan shopped wisely, that the member would save money or get an advantage. So there was no connection. And we see what we call compensation alignment with the key partners, right? So under the traditional system, which I would say is, and I'm not exaggerating here, 98, 99% of most employers today, if the costs go up, the hospital systems, on the seller side, the hospital systems like it because every seller wants the prices to go up. Now, we would expect that. That's not a big surprise. What's not known is that the insurance industry wants the prices to go up because according to ACA in 2009, they only get to keep 15% of the premiums. So they actually want the premiums to go up, which sounds crazy because everyone thinks insurance rates are the best negotiated rates. That's a myth. And then on the broker side, if the increase went up, say 9%, then that person just got a 9% raise on commissions. So that's what we call misaligned compensation. For a couple of years at Merrell Steel, I had kind of figured out this free market path. I met with Keith Smith and Steve Lantier and went down to Oklahoma and kind of I started to form this free market concept of what was happening in Oklahoma. And I started sharing it with my partners, my broker, my network, et cetera. And I found that I was dragging dead weight. They were not getting excited. They were not coming with me. And I was scratching my head. And I'm like, why wouldn't they want to win? And so I ended up doing a compensation disclosure request. This was before the CAA of 21 even came out, which says now they have to respond and respond quickly. I went ahead and did it. I said, I need to know what you're making off of my plan, both what I'm paying you and what everyone else is paying you. And I found in many cases that they were making about two sides from the insurance industry of what I was paying them. So I learned very quickly of why they were hesitant to come along because they were making more money from the other side. And so we ended up switching every single partner we had because we had broken trust. And I said, I need you to be strategic, and gave them all sorts of chances and no hard feelings. They're not bad folks, but they were caught in the system that rewarded poor plan performance, poor health plan performance. And that's exactly what we're getting in our country. Very poor health plan performance.
Sure. So how does that compare to what you do now?
What we do now is we align compensation. So we find advanced advisors that will just charge a simple PM or something like that, right? So they're not rewarded when the plan gets worse. In fact, we want to reward them when the plan gets better. We find direct care physicians, both on the specialty side and on the primary care side, that tell us a clear price. what's interesting is you can have a doctor, say under the direct care model, do say a hip replacement, costs around $20,000 on the direct care side. That same doctor could be in the hospital and do that same exact surgery for $100,000. The doctor will make more on the $20,000 surgery than on the 100. And that shows how much these, in Wisconsin, 7 nonprofit hospital systems are doing something with. Maybe it's wasteful spending. Maybe it's the next edition. I don't know, and I don't really care. But that's not value spending for the buyer, right?
Sure.
So the doctors love it as well. They can make more doing healthcare the right way than they can caught up in these big systems.
Sure. So, when I have these discussions with other physicians about direct care, you've already touched on the fact that it's significantly more affordable, whether it's for an individual or in your case for the employers who are obviously providing coverage for the individuals. And you also touched on the fact that that the physicians can do better this way. But one of the big objections that I hear all the time is, well, that's great that theoretically that could work, but it doesn't actually happen, and that's not actually going to work. And then we have places like Renovo. Tell us a little more about stuff like that.
Yeah, I used to get that a lot. I don't get that so much anymore because I think we've gained so much momentum in Wisconsin. But it was always very frustrating. It's like they wouldn't believe me. And then I would even way back in my Merrell Steel days, I would pull out graphs. And they'd almost get mad at me when I remember one broker I was talking with really got mad at me just for showing the graphs. And so I'd say, if you don't believe me, I can't show you personal company information, but I can talk certainly numbers. And I would say, come visit me in Wisconsin, and we'll go for a drive. And I'll show you all sorts of independent primary care practices. I'll show you. There's a slide I have that we can put up on the screen here that I've sent. In the last 3 years, we've seen this explosion of direct specialty care. We had no brick and mortar imaging centers for affordable MRI. Today, we have the whole state covered. We had no infusion centers, or maybe one. We have the whole state covered today. We had maybe 1 or 2 top surgery centers before 3 years ago. Today, we have almost the whole state covered, and so on. And we could keep telling that story. So I think it's real. It's happening before our eyes. So I like to joke in that regard, right? You can say you don't like it, and that's fine, but you can't say it's not true, because I can prove you wrong just by driving around Wisconsin.
Sure. So why don't you, we're going to put up that slide here so we can take a look at it. Why don't you go through it with us?
Yeah. Now, it's a little bit busy slide, but it's become kind of my favorite one in that it shows the direct primary care. So it shows the little Madison article up in the upper left-hand corner that shows that it's saying we had 15 DPCs in 2020, and that wasn't very long ago. And that I have to keep changing this number because I presented in Denver a month ago and it was 126. But today, as of this moment, it's 131. And then it shows some of the things that are happening in Wisconsin. We had, for instance, one hospital in Madison where the whole orthopedic surgery department left. There were some stories where lots of maybe some things that caused that. In fact, I have that doctor quoted in my book where I'll give you an example. He had performed a surgery, and then it was something like 9 months later, the patient came in steaming mad. And it was something like $130 or $130,000. They said, "How in the world can you get off charging like this?" And the doctor was like, "I'm sorry, I just do the surgeries. I don't know." And he went back and saw what he made on that surgery personally, and it was $900. Oh. And so these are things that led up to those kinds of decisions. But they've started their own orthopedic surgery center in that area, and I think 3 went back or went elsewhere. But there was something close to 16 or 17 total. So the whole thing they just left, and there were lawsuits both ways. Of course, the hospital systems don't like that. And we have the first fiduciary case, the plaintiff from Wisconsin, whom I know, who I talk with frequently. And we're just seeing a lot of action where employers are actually the responsible fiduciary of their health plans, just like they are their 401k. And that's something I'm an employer advocate, an employee advocate. I don't want to see employers getting sued, but if that's what it takes to spark them into action to manage this, then so be it for a while, right? And
Sure.
it'll stop. Those are some of the things. Then you see the new surgery centers and the new infusion centers and the new imaging centers. None of this existed, even as far as I think 3 years. If you go back 3 years, there were 3 bullets. There would be 3 bullets on that page.
Wow.
So all this is just really, really exploding in Wisconsin in a good way, thanks to many great physicians who are showing courage and doing what is right.
Now, on this slide, on the lower left-hand corner, you have mentioned here the Johnson & Johnson lawsuit. And I think, some of our listeners are familiar with that, but I would venture to guess that the majority aren't. And this is kind of in my mind anyway, and you and I have discussed this before, in my mind, this is potentially a huge inflection point in the industry. Can you tell us more about that?
Yeah. So there was it's called the Consolidated Appropriations Act of 21. Now, we won't get into that because it's too much detail, but there were things that were kicking in 21, 22, 23, 24, et cetera. And everything ranging from compensation disclosures, as I mentioned, that you can request compensation. That's total compensation of how much they're making off of your plan, all this under the table money that's flowing in. And also for employers, I don't think it initiated it, but it really highlighted the fact that the employers is the responsible legal fiduciary of their health plan, and that they have a responsibility to manage that health plan like they do every other area of the business. And especially when you're talking 80-20, in many cases it's lower now, 70-30. But if the employer is paying 70% and the employee's paying 30%, I can tell you this, when the employees go into the enrollment meetings, they are 100% powerless. They go in and they get the news. They had zero say in anything. So if the employer is listening to bad advice from a conflicted broker or failing to manage that health plan, they're not being a fiduciary to their employee. And I'll give you a simple example. You say, what does that mean? Well, let's say your employer was responsible for buying groceries. This is something we can all relate to because we all do this. Buying groceries for you. And then you find out that your employer is paying $120 for a gallon of milk and $96 for a dozen of eggs, and you're having to pay 30% of that. Would you not be a little upset? Would you not say, maybe you could manage this a little better? And so I think that's what's happening in healthcare. Probably multiply those numbers by 10 or more. But that's what's happening in healthcare, where for a variety of reasons, the employees are kind of the voiceless victim here. And even if they understand this stuff, if the health plan isn't designed right, there's very little they can do.
Sure. So then with the direct care model, whether it's direct primary care or direct specialty care, you're changing that conversation, and you're helping align incentives so that those employees do have a say. Can you go into that a little bit more?
Yeah. And you know what? And many would say, well, you're taking away my doctor or something. And the way we've done it, the way I did it at Merrell Steel and the way we're doing it at Self-Fund Health today, we're not taking away doctor choice. We call it kind of the left and right side of a picture that I have in the book and that we show on the screen. I can send you that one as well if you want to throw it up here. But we have a paved road and a dirt road. And the dirt road is simply one to be meant less traveled. Right? So it's, but it's still available. And this is all within the same health plan. You don't choose this in January. You don't choose either or. You can go on the dirt road on Monday and the paved road on Tuesday and back to the dirt road. But it basically means if the plan spends more, if you're spending $6,000 for an MRI when we have a brand new GE machine 30 minutes from you for $600, then we really want you to choose the $600, but we're not taking that choice away from you. If you choose to go spend the $6,000, well, then you're going to pay, the plan is going to spend the deductible, say 80% is by the company and then 20% is by the member. You're going to pay more because you're not shopping for value, but you always have a choice. And if you happen to have a pediatrician you like, then you can keep that pediatrician still within a reasonable cost, because primary care is not usually where you go broke. It's usually in the specialty care. So the patient really gains new options. They don't lose options, but we also want to teach them to shop wisely.
Sure. So keeping in mind that our audience is primarily medical students and residents and fellows and people new out of training, what do you say to them? How can they participate in this in a way that benefits them and benefits their patients?
Yeah, I would say start to align with organizations that can maybe educate. I have plenty of videos out there. There's the Benjamin Rush Institute, which is for medical students, which can help you align to maybe what would fit your career needs. There's the Free Market Medical Association, which Demetrio and I know well. You're the chapter leader for Nebraska. I'm the chapter leader for Wisconsin. There's many physicians within that and that are supporting your choice. Again, we're not trying to push anyone in any certain direction, but just letting you know you have a choice. And we find that many get the golden handcuffs, as we used to say, even back at Toyota, right, where you get in a job you really don't like, but you're paid too well to leave or something. But you come out of medical school with a lot of debt, and then the hospital will maybe have you sign an agreement, maybe even sometimes pay off a portion of that debt. But you end up in a job that's very unrewarding, very much unlike what you dreamed of. You have tons of paperwork. You spend a fair part of your time in administrative, and you have a patient load, like in primary care, for instance, of maybe 2,000 patients, when in direct primary care, the average is probably closer to 500. So instead of 30 patients a day, you can have 10 or less patients a day. And these are the decisions you want to make. If you want to go be a cog in that big money machine, you certainly have that choice. As you get a bit of a slanted approach there in how I explained it. But if that's what you want, you can do that. But if you don't, there are many other options available, especially in the states that are most active in this free market movement. I'm not sure exactly where Nebraska is today. I think we're going to try and spark that a little bit. Wisconsin's very active. Texas is becoming more active. Some of the southeastern states like Georgia and Florida, maybe a little more. But I would say maybe Wisconsin is probably, in Oklahoma as well, the model states right now.
Yeah, I would agree with that. I mean, Wisconsin is definitely ahead of where we are in Nebraska. Here, the direct care movement in Nebraska is kind of in its infancy, particularly the direct specialty care movement. And then we have employers here that are interested in exploring this, but they don't know how. And so what would you say to the employers here in Nebraska who are at least curious about what you're doing in Wisconsin?
Yeah, and my book would be a good way to learn about some of these things. What we find is these brokerage firms, these houses were built on these revenue models that don't serve the employer very well. So we see a lot of cases where an employer would switch from one broker, they realized they weren't getting good advice, or they were getting conflicted advice, and they switched to another broker, and then they've got the exact same thing. We're talking probably 90+% of the brokerage firms. So it's really hard. So maybe talking to someone who knows the area, or someone like myself who can recommend someone who's going to give you honest advice. And once you have that, you can either lead the charge yourself like I did, or find a trustworthy partner there, and then start taking these steps. Either look into an assembled plan. I don't think there's anything nationally like we have at Self-Fund Health, and we can go to other states. But to truly assemble your own plan and over time, and it can be done. There's several employers in Wisconsin that have done that over the years that I found afterward. So it can save millions, in some cases over $10 million of just wasteful spending while improving the quality of care. But I would say in choosing those partners, I spend a whole chapter on it in the book. Be very careful, because untrustworthy partners seem like trustworthy partners when you talk with them. They are excellent salespeople. So you have to have ways of discerning and understanding if what they're saying is truth, or if they're full of it.
Sure. So let's say there's a physician. I'm sure there's a physician in Wisconsin right now who is looking for you, but until they heard this podcast, didn't know they were looking for you. How do they get plugged in?
I think there's probably a truckload of them, but yeah, I think maybe they didn't realize there was a solution. I might have another thing coming out that would help with that as well. How do they find me? LinkedIn. I'm active on LinkedIn, and MATT, and then OHRT, and then Matt at selffundhealth, just 3 words.com. As are probably the best ways to find me. But if you're in Wisconsin, it's not too hard to find me, because I'm all over the state.
Sure. And do you have a copy of your book handy right there?
I do, yeah.
Can you hold it up so everybody can see it?
Sure. Yeah, it's called Save Your Company, Don't Feed the Beast, and the Employer Healthcare Success Formula. By the way, I'm a kid at heart. I've got a lot of pictures in here, and I think we're all just big kids, really. But I tried to make it so it's not textbook. You even get some good Matt humor. You may or may not find funny, but I tried to make it a fun read. Sure. And I've even got an interest. Did you see the intro? I've even got an introduction where I was run over by a tractor, a 4,000-pound tractor, and I shouldn't even be sitting here right now, but I am for some reason. So but that was kind of really what motivated my passion to do what I'm doing today.
And where can people get this book?
You can get it on Amazon, or if you want to buy like 10 or more, you can get it from me at a discounted price, and I can sign them and so forth. So a lot of times advisors will hand them out, or doctors will hand it out to employers, because I always joke, and someone says, well, how did you do that at Merrell Steel? And I always say, well, what are you doing the next 4 hours? It feels like this just forever discussion. This can be a good way if people who really want to learn, to dig in and hopefully have a fun read and come away from it and saying, wow, I know a lot more than I did before.
Awesome. Any last words of wisdom for our audience, Matt?
No, I appreciate the time. Thank you for all you're doing, that it takes great docs like yourself to do this right. And there are plenty of them out there. A lot of it is just awareness, as we talked about today. When they're aware of a better way, a lot of them will go there. They just weren't aware. They thought they were trapped in this big system the rest of their career.
Awesome. Well, thank you, Matt, for joining us today. It was exciting having you on. Would you be open to joining us for another episode in the future at some point?
Yeah,
I feel
absolutely.
like we scratched the surface today, and I suspect that a lot of our listeners would like to know more. Yeah,
we can certainly dig into any new topics. That happens a lot with the podcast. I was doing about one a week there for a while, and yeah, there's just so much to talk about, but always glad to join you. Absolutely.
Awesome. Thank you. Well, thanks for taking the time to join us today. We're excited to have you on board. Thank you for joining us on the Direct Care Movement podcast. We're excited that you joined us, and we're looking forward to having you join us in future episodes as we dive into more questions and more concerns and more solutions in the direct care space, whether it's direct primary care or direct specialty care. If you liked what you heard and you want to know more, please click like and subscribe and leave us a review. And don't be afraid to reach out to us directly so we can get you more information about direct care, whether it's direct primary care or direct specialty care.